I safe? Will this help me? Is there anyone here to help me? And do I belong? At the start of the pandemic, my family moved from 4 shared walls to 4 acres, where we were the first Black family to purchase a home in our neighborhood. Nothing prepares you for the first knock at the door. Am I safe? To jog, to wear a hoodie. Luckily for me, it was my neighbors with the welcome wagon, and they brought the good $8 cookies and the fancy tea towels. But as a person of color, when we go to the doctor's office, we don't often speak about that underlying whisper. Am I safe? Will this help me? Is that person in the white lab coat friend or foe? I have asthma, and when I was pregnant with my daughter, I had a full-blown attack, and my rescue inhaler, albuterol, wasn't working. As a clinical researcher, I know the stats. People like me are 30% more likely to have asthma than non-Hispanic whites, and 3 times as likely to die. 95% of lung disease trials have been conducted in those of European descent. Knowing more data didn't bring me more comfort. It didn't comfort me to know that 80% of pregnancy-related deaths are preventable, and Black women are 3 times as likely to die. What if my provider that day wasn't a Black female physician with similar lived experience? Black, pregnant, and she happened to know a treatment that was a little bit more effective. I wonder, would I have wound up like Erica Garner, a young Black mother, unable to breathe, dead? I am so grateful I didn't die. But did you die is an insufficient response. Morally, economically, and scientifically, we cannot deem it acceptable to prescribe medicines to populations, including those once deemed property, with whom we haven't made the effort to include in ethical clinical research. This isn't just me talking, and I know this isn't the first time that you've cared about diversity in clinical trials. With the passage of FDORA, we now have legislation and regulations that are requiring us to deliver diversity action plans. We need to show results. I believe we can. In 1863, at the age of 19, James Coleman escaped from his plantation in Kentucky and went on down to join the Union Army. On June 7th, he fought at the Battle of Milliken's Bend and the Campaign of Vicksburg for a nation where he was born a slave. Fast forward 15 years later, almost to the day, with support from his church and his entire life savings, for $1,200, he purchased the farm he was once enslaved upon. That transformed the trajectory of his life, changing not only his, but my family's. Over 300 of his descendants went to college. James Coleman was my great-great-grandfather. My name is Ryan Brown. I own a home, and my family's been involved in clinical trials. Now, participating in having home ownership, that's not unique to the Black community. But what is a little bit unique is participating in clinical trials. Somehow, the housing sector has figured out something that we have yet to figure out in clinical trials. In the left couplet, you can see housing participation by race. That teeny tiny little slot to the right is clinical trial participation by race. Both are activities that historically marginalized communities haven't been allowed to participate in. But now, over 40% of Black families own a home, while only 5 to 10% participate in clinical research. Is there anything about the story of inclusion efforts in homeownership that might help diversity in clinical trials? Good science requires good representation. Good business benefits from it. The innovations that could be possible if we had this level of representation, how much more safe and effective could medicines be? How much faster could we bring new medicines to market? People make the argument that we won't achieve diversity in clinical trials until we have a reflective amount of providers. We can't wait for that, and we don't need to. Only 6% of realtors are Black, which is eerily similar to 5.7% of Black physicians. Somehow, in aggregate, white realtors have figured out how to connect with Black and brown communities in ways that clinical trialists and clinicians have yet to figure out for Black and brown patients. So let's take a look back at history. At the start of this nation, James Coleman's ancestors were counted as partial humans in both science and homeownership. From 1787 to 1868, certain members of society couldn't own property because we were considered property. And during the same period, violence was used as a frequent tool to seize land from non-European populations. A similar mentality extended to clinical research. From 1846 to 1849, a young woman named Anarcha was given by her slave master to advance gynecological research. Her womb was sliced and pulled and wounded over 30 times, all because it was a widely held belief that Black women didn't feel pain, and there was no anesthesia involved. In 1868, we saw a small glimmer of hope, with the 3/5 compromise was abolished, and there was new creativity in financing and educational and technology opportunities for marginalized communities, churches helping people, like my great-great-grandfather, own a home. Meanwhile, in research, we didn't see the same glimmer. McDonald versus Massachusetts thereby freed hospitals and absolved providers from responsibility, even in the cases of gross negligence, from 1846 to 1957. Homeownership was out of reach for most Americans until after the Great Depression, with the introduction of innovations like the 30-year mortgage. After World War II, laws banned discriminatory practices that prohibited minorities from owning homes. In 1948, the Nuremberg Code codified respect for individuals, the right to make informed decisions, and the recognition of vulnerable groups. We can see the beats of history, where there is some overlapping rhythm with medicine and property ownership. In housing, a more diverse market meant increased economic opportunity. Selling homes to all communities made good business sense. But integration in hospitals didn't commence in the US until 1963 in North Carolina. It wasn't until 1964, with the passage of the Civil Rights Act and the Declaration of Helsinki, which really helped advance some ethical principles specifically to clinical research. The Tuskegee syphilis study continued until 1972. And now we're in a place of transition where homeownership has advanced well ahead of participation in clinical research. The big stick of legislation certainly paved a way, and efforts by people in the housing sector enabled the housing industry to make strides that we have yet to achieve in clinical research. Last year, Congress acted. With the passage of FDORA, it emphasized two broad provisions: bolster diverse participation and embrace innovative new technologies and trial methodologies and designs. Sponsors are now required to supply diversity action plans as part of their submission packages, which primarily highlight 5 key things. 1, overview of the disease. 2, scope of medicinal products. 3, you gotta define it. 4, make a specific plan to enroll and retain diverse audiences. And number 5, report out on that with the status of meeting enrollment goals. We now face regulatory requirements to show results. So what are some lessons from homeownership? What are some things that we can learn? How might pathways to homeownership and best practices in housing teach us to advance diversity in clinical trials? First, institutional innovations to reduce the barriers. Some things like the innovative 30-year mortgage tool, or consider Legacy Bank, a minority-owned bank, who is doing something rather innovative, only requiring 1% down and support with closing costs. And it's not just because the requirements and regulations are begging them and making them do it. They're competing for business. Another thing is the market doesn't have to do all of this. There are government and nonprofit collaborations, things that we saw in the housing sector, such as HUD, offering closing cost assistance and grants, Habitat for Humanity that offers educational opportunities along with low closing, low money down loans. And then institutions can find ways to help. What if we reimagined our inclusion-exclusion criteria, similar to how the housing industry is done with the mortgage and credit scores? Another thing that we could possibly do is looking at establishing really clear goals. What we've seen in the housing sector, for example, is JP Morgan has made a very clear goal and collaborates with the UNITA's US and the National Urban League with the goal of reaching 40,000 Black and brown families. Can you imagine if we made that kind of ambitious goal? The second one, write this down, is connecting with a deeper purpose. For Black and brown households in the United States, the non-financial reasons to pursue homeownership, self-efficacy, stability, and security matter far more than the financial aspects of homeownership. The feeling of finally saying, I belong. We know that intrinsic motivation is present in clinical trials. How can we connect to that deeper purpose in clinical research? It starts with person-centered care, which means really aligning and taking into account someone's values, what matters to them. And not only that, discussing the goals and pathways forward and supporting them on the journey to achieving those things. And if your team wants to get better there, I strongly recommend Faster Together course created by Vanderbilt on Coursera. Data can help us understand communities' deeper needs. Engaging our sites, obtaining the diversity site assessment tool, and really trying to understand what it takes to enable diversity in clinical trials at the site. 60% of US hospitals are nonprofit status in this country. To retain that status, they're required by law to create and develop community assessments and publish those results. The data is available, and here are some health systems that are actually doing some rather innovative things, like publishing their community action plans and making upstream investments in housing because there's clear links between health and housing. This could be an opportunity of low-hanging fruit for CROs and sponsors to fulfill the diversity action plan requirements. Number 3, show all available inventory and serve all the people. One of the rules of the Fair Housing Act is to show all available inventory. Realtors have to show it. Zillow and Redfin make it even easier. We can do this better in our field. We can better leverage data and tools and technology to serve all the people. If you take a peek here, for example, this is a really great heat map that illustrates where pockets of density are, and not only that, where the providers are that serve them. A Zillow for clinical trials is not out of reach. It's really close possibility, and we can use tools that provide visualizations of where the realtors, in this case, the healthcare providers are. And lastly, number 4, be a good neighbor. Bring the $8 cookies. The welcome wagon, the $8 cookies, and the fancy tea towels didn't find my home. They didn't make equitable housing laws. And you know what? They don't pay my mortgage. But what they did do, they made me feel welcome. Later, our property was damaged, and our neighbors not only repaired our mailbox, they restored my faith in our neighborhood. Our realtor helped us find a home. Our neighbors, they help us stay. So what could this look like in clinical trials? For my family, it looks like our white doctor inviting us to participate in a clinical trial as a care option. So that way my siblings didn't have to suffer from chickenpox the same way I did. What it looked like in practice was his team taking the time to answer our questions on a repeated basis. It wasn't a one-off affair. And they took the time to ensure that they cared to make sure our family felt safe, and the clinic flexed their schedules on weekend hours to ensure that a busy working parents could make it. So be a good neighbor. What are the takeaways? Consistently show up. Consider utilization of a welcome wagon for clinical trials. Get involved with the community ambassadors. Get involved with the community health workers. And consider those trusted sources and taking the time to make the small talk. And bring the tea towels. And a simple thank you goes a long way. We share responsibility here. Our industry has contributed to underrepresentation in clinical trials, and our expertise, our commitment to good science, and our passion can help answer those questions. Do I belong? Am I welcome? Will this help me? Will I be heard? Is there anyone here to help me? Am I safe? Thank you.